Welcome to Smoke and Mirrors, the podcast where we make sense of agricultural policy. I'm Jenny Ifft, and I teach agricultural policy at Kansas State University. Welcome to Smoke and Mirrors, the podcast where we make sense of agricultural policy. I'm Jenny Ifft. I teach agricultural policy at Kansas State University. On this podcast, we've had several guests talking about health, nutrition policy, and we do this for pretty obvious reasons. There's things people in agriculture need to know. We produce food and fiber. Also, our federal nutrition programs are a part of the Farm Bill Coalition. One thing I've been learning about recently is the food is medicine movement, which sort of ties together everything from production to health. And I'm super excited about my guest today, Marianna Wetherill. She is a professor of the University of Oklahoma at Tulsa. Marianna, do you mind telling us more about yourself?
Yeah, it's so great to be here. So at my work at OU, I actually wear several hats. I'm a professor both of health promotion sciences, and then I also work within our School of Community Medicine within the Department of Family and Community Medicine. And I'm also just incredibly fortunate to also be the associate director of our culinary medicine program here, and as well as some other roles related in the food as medicine space. But first and foremost, I am a registered dietitian. I've been practicing since 2004. And throughout my career, I've gotten to have a chance of working at an intersection of not only nutrition and medicine, but also public health and community partnerships, grocery stores, food banks, etc. And a lot of my work really focuses on the intersection between clinic and community, so that no matter where people are accessing food, there's an opportunity to promote health within that space. And then most recently, I've been able to serve as the lead advisor as well as the lead dietitian for the Kansas Food as Medicine Initiative, where we've had the opportunity to work alongside 6 clinics to design, implement, and evaluate food as medicine programs that really fit the realities of both rural and frontier communities in Kansas. And I think what's really reinforced for me in that work is that we really have to have strong relationships with local agriculture, local food systems, food retailers, community organizations to all make this healthcare initiative work in real life.
Right. Can we start off with the basics with just telling us what culinary medicine is? And then also you've talked about the food as medicine movement. How does it relate to that? Can you help us understand the space there?
Sure. So culinary medicine, we do define it as an evidence-based field where we're trying to bring together what we know about works well with medicine and nutrition science for improving health, but then also bringing in elements of culinary arts to make sure that food is something that people want to eat, as well as other strategies to support behavior change, and also realizing that people live in communities, so also weaving in some public health concepts as well. So thinking about this really as an interdisciplinary space that we're seeing more and more being offered at medical schools and at hospitals as a strategy for engaging patients in making the health behavior changes that we know that they need to make. But at its core, culinary medicine is really about helping people translate nutrition recommendations that are published in medical journals into their own lived experience in their kitchens and other places where they might be eating food and working to make those changes in the long run. Now, food as medicine is really more of a broader movement, though, where we're taking tangible nutrition prescriptions and trying to weave those into the healthcare that people can access as part of a broader treatment plan. And so we usually see produce prescriptions for medically tailored groceries. And for people with more complex conditions, we might also see medically tailored meals that are being delivered to their home. And these foods as part of a medical treatment plan are being used to help, and in some cases, even reverse certain elements of chronic disease, such as diabetes. Now, nutrition education is delivered alongside these nutrition prescription programs as part of a food as medicine intervention. And that's really where culinary medicine can come into play to help giving people some hands-on learning experience about how to use these new foods.
So it sounds like maybe one of the common threads here is if, you're trying to help somebody. I think I work in agricultural extension, so
Yeah.
I get the translation part. But I mean, if you just do one thing, help people understand what's good, make sure that actually tastes decent, make sure that they're able to buy this food somewhere. Like if you just do one of those things, you might not reach your goals. Is that fair to say?
Yeah. I think people need different types of support to get to the place where they need to get. What's nice about culinary medicine is it's delivered in a small group format. And so everybody has a chance to learn from one another and to get that, support that you wouldn't necessarily get if you were meeting one-on-one with a dietitian or even a chef. You actually learn from one another and build community as part of a culinary medicine model.
Right. So where does culinary medicine live? Are you teaching it to medical students? Would it be in clinics and hospitals? And yeah, who are you teaching it about it? How are they practicing it?
Yes, to all of the above. I am very fortunate to be a member of a group called the Teaching Kitchen Collaborative. And so for people that want to learn more about culinary medicine and what it looks like in different settings, that's definitely a website to check out. But yes, so teaching kitchens are popping up in lots of different places. We see them now in many medical schools. Today, our school was actually one of the first to require culinary medicine for our medical students. And we have a teaching kitchen on our campus where all students who are at our medical school rotate through and learn how to actually apply these nutrition prescriptions. But we also see teaching kitchens in hospitals. But teaching kitchens can also be portable. So talking about extension and going to where people are, yes, you can have a mobile teaching kitchen and do many of the same lessons for culinary medicine and experiences than what you would be able to deliver in $1 million kitchen. It's all about how it's delivered and the passion behind delivering it that usually makes the difference.
And will the I guess, what's the roles of, say, a physician versus somebody working in public health, local educator? How does that usually?
Yeah.
What does that look like? And I know it's going to be different settings.
Definitely. So kind of backing up a little bit to food as medicine models where we're talking about actually giving somebody a medical intervention that's designed for their personal health needs. The gold standard for that is for there to be a registered dietitian involved in that process. So having an opportunity to meet with a dietitian is part of a nutrition assessment that's part of that individual's scope of practice, helping that person to see what their unique needs are and how the food through a food as medicine program can be used to support those needs and those goals. For a culinary medicine model, it kind of can be a mix, though. We usually have someone who's trained in culinary arts, and then it can be a combination of healthcare. It could be a dietitian. Sometimes it's a physician, sometimes it's a nurse, sometimes it's a community health worker that's kind of playing that clinical support role in that kitchen space. But it's usually a combination of someone with that hands-on, culinary cooking experience, as along with somebody who actually plays a role in the healthcare team.
Yeah, that's great. Maybe you could give us an example of something that's worked that's more concrete, and then what do we know? What's the evidence in addition?
Yeah, so what we know is that people learn by doing, right? So we know that cooking demonstrations do not work. And they do not work because you are usually just watching someone do something rather
Yep.
than having that actual experience of doing it yourself and working through the questions that come up whenever your hands are actually on the food. So, and that's part of self-efficacy building, right? Building
Yep.
confidence and taking on new behaviors. Yes, it can be helpful to see somebody doing something, but the real magic in culinary medicine is doing it with a partner at your cooking station, and then also trying and tasting and experiencing all of
Yeah.
those foods. We know that those additional elements are what build the evidence base for a culinary medicine model.
Okay. Okay. And have you done evaluations sort of different outcomes when you get
Yeah,
all these things right?
Yeah, so the culinary medicine research is definitely growing. The Teaching Kitchen Collaborative that I mentioned earlier actually has just wrapped up a clinical trial looking at how these teaching kitchens can play a role in behavior, long-term healthy eating behavior change. But what we know from our own research that we've conducted at OU, that physician assistant students who went through our culinary medicine classes compared to students who did not had higher confidence in providing nutrition education and also higher perceived knowledge in various nutrition topics. And we know that that's one of the biggest predictors of whether or not a provider will even talk to their patients about nutrition is their own confidence in bringing that topic up.
One thing you mentioned several times is there's a lot of barriers. So if we go back to the individual or the family, a lot of barriers to having better nutrition. Can you summarize some of those?
Yeah, so I'll speak on rural, but it definitely has applications outside of rural communities. But in the work we've done both in Oklahoma as well as in Kansas, we know that rural areas consistently have much higher poverty rates than urban areas, and they also have greater food insecurity rates as well as food desert prevalence, having to travel a lot farther away to get that fresh food. Even though ironically food may be grown in that community, we just know it goes elsewhere and not necessarily in on people's direct kitchen tables. But we know that whenever resources are really tight in the context of poverty and food insecurity, a lot of families choose to purchase pretty much the exact same items every month because they're trying to stay on that budget. And it's based on what they know with confidence that their family members will eat. And so whenever we bring up trying new foods and, working towards a healthier diet, that actually can become a really risky financial choice that families feel like they can't even afford to make, especially if they're having concerns that people in their family won't eat this healthy food
Yep.
that they bought whenever there's no
Yep.
money left to replace that
Yep.
item or to offer an alternative. And so this is really where both food as medicine and culinary medicine programs can be really supportive in helping that initial behavior change, because these programs take that financial risk out of the picture for people. They're invited to try and experience new foods as part of these programs. And then whenever they're delivered in a small group, there's that added benefit of learning from each other in that supportive environment. And psychologically, it starts to feel more realistic to take that next step and try some of these foods in their own homes.
How does convenience factoring in? I like cooking in my own home, and sometimes I feel like chopping vegetables is one of my hobbies. How do you address the sort of convenience and preparation time issues in these
Yeah.
settings?
So, one, I think we have to realize that everybody's day looks different, right? So, I also really enjoy cooking. I like getting in the kitchen. I like chopping vegetables and appreciating what's in season and just trying new recipes. But there are also some days whenever I get home and I have no energy at all to want to cook.
Yep.
And
Yep.
so whenever we're working with patients or designing programs for communities, we need to incorporate the realities of the not every day is the same day. And oftentimes people, though, might be working multiple jobs. And we therefore need to make sure we have a very low entry point for being able to
Yeah.
access culinary medicine and food as medicine so that there is some space to bring that in to our lives. And so sometimes we initially start with just the how of eating. If people can't tackle the what, because they are feeling like their lives are too stressful, how can we
Yeah.
maybe bring in some mindfulness or a couple of, soft belly breaths before we eat, or eating without a screen? Different things that we can do to help people just reconnect with the food, even if it is a convenience fast food meal, but just to be more present with the food. And then oftentimes by working on the how, people become to realize that they want that relationship with food to look a little different, or they might be curious with exploring more. And then that's whenever we start building
Yeah.
in the skills and the changes.
Yep. Yep. I think about some of the things you're doing. I don't know. No, we didn't call it home economics in high school. I think when I was in high school, it was family and consumer sciences. It's probably
Yep.
something else now. But, you have these sort of, in extension and land grants, you used to have home economics departments or colleges. You had home economics educators, and we still have some of those things. They're different. We call them different things, but it sounds like some of the things you're doing are related to that work, and then some of them you're looking more at the broader sort of food and healthcare system. Is that a fair characterization?
That's fair. And I do think that there's plenty of opportunity to work with people for building both food literacy and nutrition literacy. And we know that there is a major literacy gap in both of those concepts across
Yeah,
all of America.
yeah,
We now have multiple generations where people have grown up on ultra processed foods. And while they offer convenience and have lowered costs and shelf stability, they also have removed us from what food looks like whenever it's grown out of the ground, and
yeah,
also how to work with that food to transform it into a meal. So honestly, I think the biggest challenge that extension faces and, other educators face is just getting people to recognize what food is in its most real sense, and getting away from the boxes and learning, honestly, a new language in how we're explaining food and seeing food. And then that's where perceptions of what's possible start to open up.
yeah. And I imagine in some cases you have to go kind of slowly. Sort of takes a while to change how you think about things, change how you cook. Say,
Yeah. And I think everybody's like that, right? We like
yeah.
to be in charge of our own lives. We like to make
Hmm.
decisions for ourselves. And so when we're working with our medical students, we say, "Hey, you have to acknowledge that with your patient. You have to see where they are in terms of their daily life and what they're interested in changing. And instead of giving them the answer or the
Hmm.
solution for how they're going to eat more vegetables or how they're going to eat more fiber, we encourage them to ask the patient, how can you actually see yourself making these changes and where do you want to start? And then working to support the patient in their own directive and how they want to do that. And that's a very different shift, right? Because whenever we go to a physician, the physician's the advice giver all the time. But for both culinary medicine and lifestyle medicine, it's about creating that space for the patient to do
Right.
that thinking and then owning it together as a team.
Yeah, yeah. That's great. You talked about working within the healthcare system. So I guess that's a big topic, obviously. But could you kind of dig into maybe the work you've done within hospital or insurance systems, maybe what's worked and where there's still some pretty big barriers?
So I've been doing this work for 20 years plus, and this field is changing so rapidly, even compared to 2 years ago, where we are today. I have never seen this level of interest from healthcare, insurers, policymakers, philanthropy, employers, all on the same page of now is the time for food as medicine. And interest also, what's nice and refreshing is that they completely cross partisan lines. Regardless of political affiliation, everybody gets that chronic disease costs a lot of money. And that if we can get people to be healthier, it's not only going to help people, but also families and communities to really thrive. So, thinking about what works in healthcare and what doesn't, I am a firm believer that we should lean into what we know works and use food as medicine to amplify the effects of evidence-based practice. So one example is just the role of a registered dietitian in doing medical tailoring for a patient. We know that if you meet with a dietitian and work on that nutrition literacy, that we can get clinical improvements on a lot of chronic conditions. And if we're, thinking about adding food into the mix of where we're actually giving people food, that can further amplify the benefits of just meeting and getting a meal plan. But now I actually get to experience that meal plan. So instead of undoing what works, how can we, leverage different mechanisms of support to help people really get a big return on investment there. Unfortunately, dietitians aren't reimbursed for a lot of the work that they do.
Okay.
And oftentimes they're only reimbursed for maybe diabetes or kidney failure, but they're not reimbursed for helping people lose weight. They're not reimbursed for helping people get control of their blood pressure. And so we need to work with the current healthcare reimbursement infrastructure to make sure that that profession is adequately paid, in addition to finding a way to pay for some of these foods.
So what does, I would imagine in terms of, I don't know, you got to get a code, right? But getting, moving to getting something reimbursed, part of that is showing evidence that there's real gains from these services. And do you think that we're at that point right now?
No, but we're getting there. So we have a good amount of evidence that shows medically tailored meals where we're providing people with between 67 to 100% of their nutrition every day as informed by a dietitian's assessment, that can save dollars. And we have published studies showing that. Where the evidence is more mixed is through these grocery models and produce prescription models where there is so much variation in what people get that we're at the point now where we're trying to work through and say, well, how much do they actually need to get and for how long before we can expect to see a benefit? And the American Heart Association has invested heavily over the last few years in trying to build that evidence up because we know that that's the data that health policy makers and insurance companies really need to know in order to make those decisions. I do like to remind people, though, that the WIC program is an evidence-based food as medicine program. It is the oldest food as medicine and largest food as medicine program in our country. And so we know that model works. It really can help support maternal health, improve birth outcomes, learning, all of that. So we're just now trying to figure out, well, what combination of foods and services are needed to support other health outcomes that aren't in that prenatal space.
Right. So let me see if I get this right. Pop quiz for myself. WIC is for pregnant women or women with young children or parents with young children. The income bar is not quite as stringent as for SNAP, and they get an EBT card. Okay, I'm doing okay so far. But they have to use it for certain approved foods. So vegetables.
Yes.
I don't know about meat or milk. There's certain things that are approved.
Yes. So the WIC program was designed to help address explicit nutrient gaps that are associated with pregnancy risk, nutrition-related pregnancy risk. So think about iron, think about calcium. And so a lot of those foods were selected to help fill those nutrient gaps. So that is how a medical tailoring works for food as medicine. We're thinking about, well, what is this person? What are their nutrition needs? What do we think they're at risk nutritionally for, and how can we provide them with foods to help with those gaps?
Okay. And so what is the eligibility period for that?
For WIC?
Yeah, I don't recall. I don't know if I've ever looked it up, actually. I'm curious now.
So WIC is available to lower income women who are at nutritional risk, and they can enroll during pregnancy, and then the child can benefit from WIC all the way through age 5. And you can enroll at any point, during that process, and it'll depend on if the package is benefiting the woman only, if it's during pregnancy, breastfeeding or not, and then the child. And so you can also have a family where it's a single father or a grandparent who's raising the young child, and they can enroll in WIC for the child. Yeah.
That makes sense. Have you worked a lot? And WIC is one that you mentioned that's it is food as medicine, let's say. I don't know. But then there's SNAP, Supplemental Nutrition Assistance Programs. There's other ones as well. Do you work with any of these programs or see them fitting into what you're doing?
Definitely. So if we think about food as medicine as a healthcare intervention, it's operating on top of community level factors that, also influence food access. And we can't talk about food as medicine without realizing, what is that foundation part of the pyramid that's holding up these higher level, more intense, models of care. And so federal nutrition programs are really foundational because they are already built within our system. They're reaching millions of Americans, and food as medicine needs to complement, but not necessarily replace programs like WIC and SNAP and school meals and senior nutrition programs, et cetera. One, really great policy that we've seen is, offering of nutrition incentive programs that are sponsored by the USDA. And in Oklahoma, our program is called Double Up Oklahoma, and it allows people who receive SNAP to get extra matching dollars to purchase fruits and vegetables so that they can stretch their limited budget and also afford those healthier foods. And so if you think about a food as medicine program that oftentimes is trying to get people to eat more produce, that program is only usually for a 6-month period, or at best maybe a year, and then you graduate. So there has to be resources out here in the community so that people can maintain that health behavior change. And that's where I see some of these other federal nutrition programs playing a role, particularly those nutrition incentive programs.
Part of it is just, this is the system we have. But I mean, regardless, it's not enough. That you also need community resources, whatever those look like, to help these food as medicine models work. Is that fair?
I try to think about it as a no wrong door approach for food as medicine. So a lot of people who experience complications from their chronic disease, they actually may not have a source of health care. So they might be going to a food pantry to get food assistance. What would it look like if that food pantry started asking if that person had diabetes or hypertension or whatever those chronic conditions were? And also then we're working with a FQHC or other clinic to help get that person connected to the care that they need. And then simultaneously, whenever we're in a healthcare setting, what if we actually started asking people what they eat and initiating some conversation so that everybody is hearing it kind of from different angles and we're not letting anybody fall through the cracks?
Yeah. Do you ever work with libraries? They provide so many public services these days.
Yes, I think libraries are such an untapped opportunity for food as medicine outreach. And we've actually been exploring, our team have been trying to figure out, well, how can we more proactively get libraries into this fabric of food as medicine providers? Because you're right, there's usually a library in almost every, community, and that's the place where people go to get their information.
Maybe we've touched on this all already a little bit, but I do want to be explicit about scaling.
Mm-hmm.
So it sounds like from your work and other stories, anecdotes I've heard, that there have been a lot of documented successes.
Mm-hmm.
But what do you see as sort of the opportunities and challenges for scaling this?
Yes. So the biggest problem or dilemma that I think we're working through, especially those of us who are in rural health, is although there's a lot of growing evidence for food as medicine, it's oftentimes being done in very urban communities where there's a lot of centralized resources. And so you can't very easily take that information and that evidence and then apply it to a rural healthcare setting, as we all know. So this is a major barrier to being able to scale and really have this healthcare innovation make it to rural America where people could benefit the most. So what we need to do is lean into our rural communities and try to get as much information from them about what's working and what's not, and being more proactive with engaging in these national conversations and saying, hey, how does this apply to the needs of rural America? How would this, food as medicine structure, is that something that could work in this community setting where, for example, there isn't a dietitian? And even with money, they can't find one to work. What would telenutrition look like? And is that an option, for example? So we definitely have a lot more work to do, but I am excited about what these next few years are going to teach us as we work to roll food as medicine out in Kansas.
And how do you see social media and AI playing a role? That's a fun one, right?
That's a fun one.
Trying to figure that out myself.
I know. People learn from social media, whether or not they're learning the right thing or the correct thing. That's debatable. But I think for us working in this space, we have to be willing to work with it. If that's where people are getting their information, we need to be participating in those same kind of media structures to make sure the information is getting to people. In terms of AI, similarly, yes, I want people to have access to a dietitian, but what if there is no access? I do think that AI can help people get at least part of the way there. And we just have to, of course, be conscientious and find a way to help people know fact from fiction and what might be produced from the AI.
Yeah.
But
that's how we talk about it in extension.
yeah.
But I'm curious, how do you train physicians or physician's assistant, any healthcare provider or an educator, when you have somebody that comes to you and said, this influencer said this, or I read this on, social media or AI, like, how do you approach those conversations?
Yeah. Even if the person is coming with information that may not be factually accurate, I usually start with praising the person and acknowledging the person for having interest in wanting to make that change in their health. Usually there's a little bit of truth to whatever is in, that piece of information. And so I usually try to dissect it and differentiate out what's evidence and what might be just hype. Usually for most patients that I work with directly, or whenever I'm working with providers too, I really emphasize, though, getting as much diversity of plant foods as possible. So maximizing color for your fruits and your vegetables, and then trying to get in as many varieties of beans and intact grains that we can, because our bodies evolved off of a lot of plant diversity. And as we know today, most people only, have wheat and corn in a highly processed form, and their vegetables are in the form of French fries or mashed potatoes. And our microbiome suffers as a result of that. And then our body metabolically also suffers.
That makes sense. I'm taking notes for sure on that one. I think everybody's working through that.
Yeah.
Is there anything on the rural health side that we didn't cover that you thought I was going to ask or that you'd like to make sure we bring up?
I think it's just really important as we work to advance food as medicine within rural communities that we don't forget about our rural grocery stores, many of which are, independently owned, or they're a part of just a very small chain that operate on very razor thin margins already. And anything we can do to invest in that rural grocery store so that they can be part of a food as medicine model, it's a win-win for the whole community. We're getting ready to launch a study actually looking at rural grocery stores in Kansas to see, do they even have the foods on the shelves that we oftentimes recommend as part of a food as medicine, model. So for example, do they have sunflower seeds available, or pecans or other nuts and seeds? And then if they don't, how can we work to build out that local food infrastructure so that maybe they can start offering those foods and also maybe supplying them as part of a food as medicine design?
So you got to do a PSA for the Rural Grocery Initiative here at K-State. I think they're doing a lot of work to keep rural grocery stores going, and
Yes.
It's definitely a tough business. I didn't realize. I just met with somebody a couple weeks ago. It is a tough business. Oh my goodness.
Yes. I mean, 1%, 0.5% profit margins. It really is razor thin.
Is there a role for meal delivery in rural areas?
That is definitely a big limitation for scaling. So, for example, medically tailored meal programs, there's often a delivery route and they serve thousands of people per day in a single community. Well, obviously, that is not translatable to rural America. The other important part of our food safety net system in rural America is the food banks, though.
Yep.
And they already have delivery routes, and they oftentimes go to communities that don't have grocery stores and where no other food, vendor is going. So if I were to look into a crystal ball and forecast the future, I would really see and hope that our food banks have an invited role to play in these food as medicine initiatives because they've been such a critical part of the fabric of communities, and they need to stay that way to help keep these models local.
Absolutely. What about Meals on Wheels? I remember that from growing up.
Meals on Wheels is great. They definitely, I think, fall within the foundation of, other food programs. Meals on Wheels do not necessarily meet the gold standard for food as medicine because those individuals don't get assessed by a dietitian to inform the food that they get, but they definitely have a lot of resources and infrastructure where that dietitian element could be integrated. So thinking about, again, working with the assets that we have, and then how can we infuse a little bit more resources strategically to help build that capacity.
And so my observation, I guess, to switch to the school lunch program, because I have kids that are school age now, work that they have to do, because they have nutrition guidelines they have to meet. They have to get stuff that kids will eat on a budget with managing the supplies. And then everyone's giving them a hard time from all different angles. I mean, that has to be one of the hardest jobs for the director or a dietitian. I can't imagine.
I agree. And then I applaud anyone who works in that space because you're also working up against food norms and preferences and learned taste that are oftentimes the opposite of a healthy food menu, and so trying to change that abruptly is not to work in a cafeteria. We have to include additional things within a child's early experiences so that they will be open and wanting to eat broccoli if it's served to them in an elementary school cafeteria. If we just present the broccoli, it's not going to magically be eaten because they may not even know that it's broccoli, right? Right. So we really need to work at a much younger age to try to, again, change what people see as food.
A couple years ago, there was like a big controversy over taking out deep fat fryers. Now we have whole milk back in the schools. I'm thankful for chocolate milk because I know my son drinks it. Yeah, there seems like it's sort of, some things we've gotten to be whole grain now that seems like they've kind of figured it out. Now, where's I guess from the perspective of a dietitian or professor in that space, where are we at right now with all that?
Yeah. Well, I am not a child nutrition expert. I will put that out there, although I do have an 8-year-old daughter, and I empathize with parents who cannot get their children to eat vegetables because my child is very much like that. And I think it's really, again, difficult to expect any policy to have an impact on the nutrition status of a child if the child won't eat the food. So, really taking that step back and saying, well, what do we need to do immediately and long term so that our children will be willing to eat the foods? And for me, the more fiber, the better. Most children have constipation and they're experiencing that constipation because they're not eating, plant sourced foods in their supply. There's room for meat, there's room for milk, but there also needs to be room on that plate for that diversity in plant foods too.
And I've have one kid that eats anything and one kid that the fight is real and it's different.
Yeah.
That's a little bit off track, but yeah. Is there anything that you feel like is commonly misunderstood about the work you do?
Yeah. So one thing people often misunderstand, I think, is that changing what people eat is simply a matter of educating them or them finding enough willpower to make that change. We're a very individualistic society, so that's oftentimes that default line of thinking. But if that were true, we would have solved all of these problems decades ago, right? We know that food choices are shaped by a lifetime of experiences. And unfortunately, oftentimes that's shaped by childhood adversity, financial stress, food traditions that oftentimes now include a lot of these processed foods as, quote, family foods. But then also other sources of trauma, environments where people live, all of this shapes our food choices and our relationship with food. And especially in rural communities, generations now have had multiple economic uncertainty, food insecurity, natural disasters that might take away a grocery store, for example, loss of local industries. And all of these experiences, cause people to rely on foods that are affordable, familiar, filling, predictable, and oftentimes these are unhealthy foods, right?
Yeah.
But so rather than viewing these foods as unhealthy choices that people are making, I think it's a lot more productive if we realize that people have adapted to some really difficult circumstances. And actually, our communities are very resilient. And so a good food as medicine program needs to recognize that and needs to build on people's strengths rather than entirely abandon who they are.
Makes a lot of sense.
Yeah. A different angle. Yeah.
Yeah, absolutely. All right. So let's say that you get to change one policy. What would it be?
I think what I will say is that one thing I've learned and that I think we're all starting to appreciate is that health does not begin in a clinic. It begins way before that shape whatever problem a person is showing up with. And it stems from decisions that are made on what to grow in a farm and what food manufacturing practices are allowed, what's available at retailers, and what, as we've talked about, are, distributed through our schools and through our other institutions. And so for me, the most important policy change would really be at looking at any policy and thinking about those connections with agriculture, nutrition, and healthcare as a unified system rather than as a separate system. And the more we can get those sectors to work together and to be incentivized to work together, the more likely we are going to actually make an impact in people's health and well-being.
And there's a lot at stake, right?
Yes.
All right. Well, thank you so much for your time. I certainly learned a lot and really appreciate it.
I was happy to be here. Thank you for having me.
Thanks so much for joining this episode of Smoke and Mirrors as we dig into the policies driving food and agriculture today and in the future.